I'm Dr. Tom Kaiser. I'm going to talk to you today about the preservation of the upper limb function following spinal cord injury. And let me show you my objectives of this talk. We're going to try to learn about upper limb function and how it's critical to the health of spinal cord patients and their quality of life. And then discuss appropriate methods to protect the upper extremity as they're doing their daily activities, pushing their wheelchairs and other things, and then a treatment method to manage upper limb injury and spinal cord injury. If they get an injury, I'm going to talk a little bit about how to manage that, and it'll be a little repetitive. There's some particular issues that you'll pick up on that'll be a recurring theme throughout the talk. But when you look at what the upper extremity does in spinal cord injury, it shifts the dependence after spinal cord injury. When they become paraplegic or tetraplegic, it shifts the dependence for mobility to the upper extremity, and this increases the risk of injury because the upper extremities are made for hand placement and reaching tasks, but not for weight-bearing activities. And it's also magnified because over their lifetime, they're repetitively using their upper extremities much more than you or I would do in a normal day's activity. And then finally, when they get an injury, it's very negatively impacts their function. If they don't have their arms and you're a tetraplegic or a paraplegic, it really decreases your quality of life and your ability to function. So if we talk about the management of upper limb pain, when you look at the arm and the spinal cord, you treat it very similarly to a able body or a patient without a spinal cord injury, but you want to plan your interventions and manage the acute pain to prevent it from developing into chronic pain. And then the other issue you want to do is you want to consider rehabilitation techniques, not only medical techniques, when you're managing these patients, because they're different in how they get around and how they use their arms than your normal patient that walks into your clinic. So the guiding principles when you're managing upper limb function and upper limb injury in these patients are to beware of negative interactions that can happen if they're using complementary or alternative medicines. You want to ask that question: what are you doing? How are you managing this pain? Are you doing anything that's outside of the box? Are you using some type of home remedy, which they often do? And then you want to look at narcotic use. Narcotics have a negative impact on spinal cord patients, in particular because they have neurogenic bowel. And if they have a neurogenic bowel, then that will narcotics will affect their bowel program and how they manage their bowels. And so you want to use it when you need it, but try to keep it short. You want to avoid activities that strengthen or stretch that make the pain worse. So a lot of times I'll order therapy for a patient, and they come back and say, man, they really hurt my arms with the activities they were doing. And so you want to know what the therapists are doing, how the patient's doing, and if it's getting worse, you need to modify those activities. And then the big thing is you want to avoid activities that cause impingement. And impingement are the things, if you think, if you're a physician or a medical student, near sign with internal rotation and a forward flexion it causes impingement of the shoulder. Internal rotation, abduction causes impingement. And those are the activities that you want to avoid. I remember talking to a patient who says, boy, every time I reach up for stuff, it hurts. And I just talked about doing it palm up, which takes the greater trochanter out from underneath your acromion, and they could do that without pain. And so if you just kind of teach them simple techniques when they're reaching above head, that can be very helpful to your patients. Yes.
Push the presentation button, please.
Oh, we're not on the presentation. I'm sorry. Yes, I will do that. Sorry about that. You're seeing all the other slides. Okay. Proceeding on, the most common injuries that occur in spinal cord patients are carpal tunnel syndrome, which with an incidence of 40 to 66%. And you have to be aware, some of these patients don't have good sensation in their hands, and some of them can frankly not be aware that they're having median nerve damage because of the lack of sensation. That can happen in a large majority, 15 to 48%. And then shoulder pain is a real common problem, both in paraplegic, but especially in tetraplegics, because you can have the level of neurologic change can often be in the C4-5 distribution, which is around the shoulder, and that accentuates their pain. And then the other injuries that can happen that you need to be aware of, ulnar nerve entrapment, both at the elbow and the wrist. You can have epicondylitis, both medial and laterally, depending on how they do their activities. osteoarthritis, of course, with overuse, olecranon bursitis, rotator cuff tears, bicipital tendonitis, myofascial pain, or other things that we see that you need to be aware of when you're working these patients up. So when you're managing upper limb pain, you want to emphasize maintaining optimal range of motion. You don't want to lose shoulder range by your treatment strategies, and you want to maintain the range that they have. You want to look at alternative techniques or activities. What causes your pain? What makes it worse? What makes it better? And then you can alternate how they transfer, how they move, how they reach, how they dress to protect their shoulders. And then if your treatments aren't working and they're not getting pain relief with your activities, you need to step back, look again, see what am I missing with further workup and treatments. And then if they have an upper extremity fracture, very critical in the spinal cord patients, because that arm is so important to them, to stabilize that fracture early. Usually you'd want to do some type of internal fixation so that you can get them back to activities, do range of motion activities, and not have to splint them or cast them and lose range. So you want to be aware of those issues with your spinal cord patients. Now, if with all your activities and you're trying to manage their pain and prevent pain, they develop chronic shoulder pain, you want to go through the workup. So if they show up and you're not doing well and it's kind of developed into chronic, you want to know what's the etiology of the pain, what makes it better, what makes it worse, what's your pain intensity, how does this limit your capacity to transfer and do. And then finally, is this causing undue stress on the family and yourself? And are you having problems with sleep because of the pain? Are you having social stresses? Are you having to ask your wife to do more? How is that affecting your relationships? And then if they're using illicit drugs or overusing alcohol or prescription meds, you want to be aware of those things. Now, the things that increase your risk of upper limb injury in spinal cord patients are if you're older. Your older spinal cord patients can have problems. If they have a change in medical status, so if they get sick, UTI, pressure sore, where they can't quite do as well, they're weaker than they used to be, their transfers aren't as good. Pregnancy is one of those things that if your patient is planning on getting pregnant, if she's a female, how's that going to affect her transfers, her mobility, pushing her wheelchair, bowel bladder issues, and sometimes they have to transfer more often, which puts more stress on their shoulders if they're pregnant and their bladder's emptying more often. So sometimes you think about a Foley catheter during that time frame to protect their shoulders. And then if new medical problems develop, they develop heart disease, diabetes, how is that going to affect them? And then any weight gain is going to put problems on their shoulder. Again, if you want a workup diagnosis, very similar to the able-bodied population. If you're looking at carpal tunnel syndrome or nerve impingement, an EMG nerve conduction study can be very helpful. X-ray of their neck can be helpful, or MRI if you're thinking radicular pain. And then ultrasound can be very helpful, especially for the shoulder and elbow, to look for nerve entrapments. Now, the ergonomics, when you're looking at your spinal cord patients, you want to, minimize their frequency of repetitive limb activities, especially for overhead reaching. You want to minimize the force required to complete upper limb tasks, how they dress, move, turn themselves in the bed. And then you want to minimize the potential injurious positions, which are extremes of wrist deflection or extension. Positioning the hand above the shoulder. We like to have most work activities down low so they're not reaching over their head. And then, of course, that internal rotation, abduction, which causes impingement, which can be harmful to their rotator cuff, especially the supraspinatus. Now, when you're looking at equipment and environmental adaptations, your high-risk patients, the ones that are already developing shoulder pain early on or having trouble with transfers, you want to look at do they need power mobility assist earlier or power wheelchair earlier than they might otherwise need it. You want to keep their wheelchair as light as possible, a lightweight wheelchair. And then if they're looking at a manual wheelchair, how you adjust the rear axle, which I'll go into a little more detail, will affect how they push and how they move and how they transfer. And then the angle, how high you put them up, the elbow angle, you typically like when they're sitting in a wheelchair to be 100 to 120, not too straight or too flexed, or that may add increased force on their arm, and that's when the hand's at dead center. So with the rear axle, if you put it as far forward as possible, you're putting more weight over the axle, so that decreases rolling resistance and improves their propulsion efficiency because they can reach farther back to get a better push, and you can lower their stroke frequencies. They're not having to push as often. And then you also need to watch out for, as you move that axle forward, it makes the wheelchair more tippy and can cause them to go back. So you want to move it as far forward without compromising their stability. So this is a cartoon picture of somebody sitting in a wheelchair with the optimal, which is this mid picture of where you want their angle, about 100 to 120. You don't want them sitting too low where you got a 90-degree angle on the push rim, or you don't want them sitting too high where it's less than 100 on the push rim. So to minimize the force required for upper limb tasks, you want to maintain ideal body weight. You don't want them to be too heavy or gain too much weight. You want to improve their propulsion techniques and sitting position in the manual wheelchair, and I'll show you some pictures of people in wheelchairs and how to maximize that. You want to ensure optimal body mechanics during weight bearing, such as when they transfer or when they do a pressure relief. Switching to power wheelchair when appropriate. And, it's an expensive choice, but it's also very expensive to have somebody come in and help them because of their shoulder pain prevents them from doing ADLs and transferring themselves. So you got to think ahead on those things. Now, to minimize high loads, a lightweight wheelchair, which we would call a K4, which is right here, usually weighs around 30 to 35 pounds, where an ultra lightweight is below 30 pounds and is a K5 when you're looking at the billing purposes. And, the higher force applied to the push rim on a wheelchair increases the risk of median nerve injury. So if I can get a lighter weight wheelchair, that push force is decreased just because the weight of the chair is decreased. Now, the other issue is with wrist motion. Increasing the wrist motion or how far they reach back and forward actually has been shown to be helpful as long as you minimize the forces on the wrist. And so a lighter weight wheelchair, less force to push, so less force on the wrist and the hands and the shoulder. It's more customizable, so the lighter weight wheelchairs have more features. They're not just a standard adult wheelchair, so you can customize it to help the patient push better and sit better. It's made of better components, so they last longer. Dampens vibration, which can damage the shoulder and the spine and the wrist if they're getting a lot of vibration through those things. And over time, there's been studies that prove that a better wheelchair costs less to operate because they last longer and there's fewer catastrophic failures of the equipment. So this is a picture of an ultra lightweight wheelchair. You can it's a cantilever style. It gets rid of a lot of metal. I'll show you a picture of a lightweight wheelchair in a second where you can see a lot more metal down here, more of a box frame. It has lighter weight wheels with fewer spokes. And then if you look at a lightweight folding wheelchair, then this has mag wheels so the spokes don't break, but that makes it heavier. Flip back armrests, and the armrests are heavier. You can see this box frame and more metal there. But a lightweight wheelchair, which would be 30 to 35 pounds. And then if you get into the standard adult wheelchair, the old E&Js, they get you up in the 45 to 50 pounds. You can see over a person's lifetime of pushing a heavyweight wheelchair, there can be issues. Now, when you look at wheelchair push mechanics, how does the patient push a wheelchair? So you can watch how they do that while they push into your clinic space, and you can kind of monitor how they do it and move around when they're there. It's often good to get them to also watch them to transfer. But you want to have long, smooth strokes to limit the high impact. You want to allow the hand to drift down naturally. You don't want a lot of abnormal motion where they get a lot of shoulder motion and head motion and body motion. So you want them to be a relaxed state where the hands can drift back and grab the push rim naturally. And then you want get appropriate seating position, and you want them to have a real stable base. So this is just a picture of hand motion. There's the A motion is what we kind of want, and this is the forward part of the wheelchair, and this is the aft part of the wheelchair. And the the hand tends to contact on the back part of the wheelchair, pushes all the way forward, and then there's this relaxed swing back motion that you want till they contact the push rim again. And so it's just a nice, natural arm swing versus somebody who's doing a lot of frequent pushes with very short strokes, and they're not getting and they're raising their arm up and probably their shoulder up, so they're just wasting a lot of energy. It's not very efficient, and it puts both their arm and hand at risk because of increased frequency of pushing and abnormal motion. Now, this is a picture, and I use this picture a lot in my presentations, but an old patient of mine who was in a very small wheelchair when we first put him in it, which was inappropriate for him, versus on my right, your left, you can see him better positioned. Now, this is an ultra lightweight wheelchair. The first one, this is a lightweight wheelchair, and you can see the added metal in this one. But what I want to point out is that the wheelchair is much too small for him, putting increased pressure on the feet, the lateral legs, and the ischium as you push the legs up. And, his arms are kind of internally rotated and positioned poorly, whereas if we put him in a wheelchair that fits him better, he's got less pressure on his feet, no pressure on the leg rest. He's got good pressure underneath his distribution, and he's sitting more comfortably in a better posture. And, if we don't have a picture of him touching the push rim, but you need to raise that seat up a little bit because his arms are going to be hanging down pretty low on this wheelchair. So when you look at sitting position, you want to adjust the sitting and the trunk support to provide a stable base. You don't want them shifted to one side or other to have a pelvic tilt. And you want them to not have any instability. So when you're doing this, you want to stabilize the pelvis first when you put them in the wheelchair. You want to make sure their pelvis is level and stable. Then you look at the lower extremities and how the foot plates reach, and are they long enough. And then finally, you look at the trunk and how the trunk's positioned. Now you have so once you do that, then you want to look, are they flexible in their spine and pelvis? Because if they're pretty flexible, then you have some room to position and use your equipment to get them neutral, midline pelvis, normal cervical and lumbar lordosis with good posture. However, if they're fixed, you're going to have to good balance and ADL and reaching and stability with what their fixed deformity is, which makes your job a little tougher. Now, with trunk support, especially for the high quads, if they don't have good abdominals, good upper trunk, they're going to tend to fall. So you're going to need to stabilize their upper trunk as much as possible. You make special accommodations for the tetraplegics, especially the big, tall tetraplegics. If you get somebody 6'4", 6'5", put them in a wheelchair, they tend to sacral sit, which makes, when they're sacral sitting, forward shoulder position, when they reach, they have more trouble. If you can get them with the shoulders back, the pelvis up, then when they reach, they're not in the impingement position. So you want to really strive for, a good posture if you can, and avoid the head forward kyphotic posture. If they're C4, you also want to think about forearm support, shoulder support, because if they're C4, they have very minimal rotator cuff muscles, and so their shoulders are hanging on their rotator cuff muscles, and they're going to have shoulder pain. So you want to avoid subluxation with good shoulder support. Now, pressure relief, and we teach our patients how to do pressure relief to protect their skin so they don't get skin breakdown. The first guy, as you can see, is a paraplegic who's doing a wheelchair push-up with their hands dead center. We usually tell them to lock the wheels when they're doing this. But you got to watch, and, his shoulders are kind of down, shrugged. We'd like his head to be up and the shoulder depressors pushing down, because this is putting him at a little risk of impingement. Our quads that don't have tricep function but have C6 function and wrist extensors, they can lean side to side, which kind of helps with pressure relief. It provides good mobility, but then, puts increased force on the wrist. So, we teach them how to do this, but you really got to watch out for problems. And then sometimes that's when you got to go to power wheelchair mobility so they can do pressure relief, so they can do different activities. So when performing weight lift or weight shifts, you can do a forward lean. If you're sitting in your chair and put your hand under your ischium and lean forward, you can feel the weight coming off your ischium, and that's a good pressure relief. Side-to-side shifts, as I showed with that one individual, that can also be used in patients, and then the depression style where they're doing the push-up. If they have a power wheelchair, of course, power tilt is an option where the chair just tilts back in a sitting position. There is a power recline where the back goes down and the legs come up and they're lying flat in the chair. And then you can order them an alternating pressure relief cushion where it's a cushion that has different air bladders that just alternate so they get pressure relief. And all those devices can be used in their wheelchairs to kind of protect their shoulders from having to do a lot of activities. So when do you consider a power assist wheelchair? When they're having a lot of repetitive injuries and they're a high-risk patient. So if you got a guy who's getting older, starting to develop a shoulder pain, you're sending him to PT and OT a lot to kind of learn how to manage his shoulders, and he's still having pain, those are the patients that you may want to think about going to some type of power wheelchair or power assist wheelchair. Or if they're getting obese, if they're getting older, or they live in a very challenging environment with a lot of hills. Some of my college students who live on a hilly campus sometimes need some type of power assist. And then finally, power wheelchair increases the risk of weight gain. So if you're going to put somebody in a wheelchair, they're going to be less active, they're going to burn less calories, and there's some risk of upper limb deconditioning. And you have to talk to them about that fact and how to counteract those things. This is a picture of a Power Assist Smart Drive, which is attached to a standard wheelchair and attaches to the axle. There's a little attachment mechanism here, and you can see the handle where you can lift it on and off. So this is something that you can put in your trunk and then use as you need. It's activated by a wristband. My sister, who's in a manual wheelchair, just got one of these. Her shoulders are starting to bother her, and it's been very helpful for her as she's pushed around, especially if you're outdoors doing outdoor activities and going up and down hills. This can really save your shoulders. Now, the other thing is a power seat elevator is something you can add to a power wheelchair, or there are some standing frames that you can get in a manual wheelchair to help people with reaching tasks, but it helps with upper limb function. Again, for the reaching, provide seat elevation or a standing position for weight bearing and stretching and to manage spasticity, and it can help prevent reaching overhead, and increases your likelihood, at least in a seat elevator, of a level transfer. And if you don't have to go uphill a lot or overhead reaching, you can really help things. I had one of my patients who was very proud of himself. He got an ortho frame and put a bunch of straps over his bed and was able to become independent with transfers, and his family didn't have to help him as much. But the problem is, over time, he developed shoulder problems, and at a younger age, had to go to power wheelchair, and had to get help with transfer. So you really got to watch how you modify activities. But the seat elevator or standard can be added to a power wheelchair. You want to assess how this is going to help them meet home modifications and help with these activities. If you're going to transfer level surface, I've already mentioned, but you also want to avoid the overhead, like my guy with the straps on his ortho frame, because he was putting his shoulder in impingement. You want to avoid a flat hand when you're transferring, especially in the high quad, and I'll show you why in a minute. And then you want to vary technique with your leading arm. Your trailing arm is where you provide most of the pressure, and if you can vary your technique, you can avoid a lot of pressure problems. So this is one seat elevator, with just a central pan that lifts the chair up and has about an 8-inch rise, and so they can get high enough to reach something that's overhead, avoid shoulder impingement. They can elevate this so that if they're getting in and out of their SUV or they're transferring in and out of a higher bed, they can be at level or above to make the transfer easier. These are other standing wheelchairs, and this is a power wheelchair with a standing feature which they can go into, and this is another one that that instead of the seat elevator, you can just kind of stand them up. Now, the thing to notice, they have to have something to block the knees, and they have to have a chest strap in general, especially if they're a high quad. And there are manual wheelchairs that work as standers, again, with the forward knee block and some type of a chest strap that they can use to get to a standing position. And some patients that give talks like I'm giving today like to be in a standing wheelchair so they can be upright when they're talking to folks. Also, with the reaching task, it can be very helpful. They do make a chair where you can just kind of push up and the seat raises enough, and just like a computerized chair, so they can just raise up. They push a button and lower back down. That adds to the weight of the chair, adds to the complexity of the chair, but it can be very helpful. And then a patient of mine sent me this picture of his tractor with a standing feature that he uses for hunting and getting out in the woods. And he tells me this is pretty stable. He has not turned it over yet, and he's a pretty aggressive guy. So they do have these devices available for your more energetic patients. So when we talked a little earlier about the bearing transfer techniques. Again, the trailing arm, that's your pushing arm. Your guiding arm is a forward arm with the transfer, and so it's going to provide more force through the arm. So you do want to kind of vary. If you're always transferred to the right, always pushing, with that left arm, then you might have more trouble. Repetitive transfers in the same position can lead to problems, especially pressure. The vascular, the rotator cuff, supraspinatus is one we see a lot of problems with. And so when you're transferring, you want to get your weight over your arm as much as possible. If you can protract and depress the scapula to get it down, get the shoulder up, you get less of a impingement syndrome, and you get your weight over the glenoid and less force on the rotator cuff. Again, I talked about the hand transfer. I have a picture of somebody transferring here in a second that I'll show you. But if you have a flat hand transfer, then you're overstretching the finger flexors, which can, if somebody's using tenodesis grasp, can be very detrimental to their functional task. You want to, if you're extreme extension, you can cause increased carpal tunnel pressure. You usually want to allow your fingers to drape over the edge of an object you're transferring to, or you can bend the fingers so that they're not overly stretched to preserve the tenodesis, especially in C7 and above patients. And so this is what tenodesis grasp looks like for somebody who has C6 function but no C8 or T1, which is where we get our finger flexors. They can open their fingers with wrist flexion, and then when they go into extension, those fingers come together and they can grab a phone, a utensil, piece of paper, and use that without any hand function at all. And we want to preserve that tightness in those fingers, because if it gets real floppy, then they lose the ability to grab things. You can often add a tenodesis assist device, which a lot of my old patients have. The newer patients don't tend to like this device because it's fairly ugly, but a lot of my guys, the old guys, tend to like it because it really helps their function, allows them to grasp things without needing extra help. So again, level transfers whenever possible. You want to avoid that impingement position when you're transferring, and typically that's my guys getting into an SUV, pulling themselves up into bed, and then avoid flat surfaces with the entire hand to avoid high wrist pressures. Again, allow the fingers to drape and preserve tenodesis. So this is a picture of somebody transferring on a sliding board to a mat in a PT gym from his wheelchair. You can see he's got his weight over his hand. He's got pretty extreme extension of the wrist, which, with somebody who has C6 function, which it looks like this gentleman does, because he may not have C7, because if you can get the hand down on a surface and you can lock your elbow out with your bicep, you don't need triceps to stabilize yourself. But you can see he has the fingers kind of flexed. He doesn't have the fingers out straight to try to preserve his tenodesis. And he's leaning and he's pushing with this trailing arm to slide over. And it's a pretty level transfer. The wheelchair may be a little higher. And you can also see his feet are on the floor to stabilize himself. So this is kind of a standard transfer. If we get somebody to go right and left and vary their technique and how they position their hands, that will preserve their upper extremities. The other thing I want to talk about is bed positioning. When you look at the upper limb in somebody with paralysis, you want to avoid direct pressure on the shoulder, especially if the shoulder is unstable in a C4, C5 patient where they don't have good rotator cuff. You want to provide support to the upper limb at all points. You don't want it dangling or hanging or pulling on the rotator cuff. When supine, position the limb in abduction and external rotation, as much as possible, because we tend to sit like this all the time and get tight. And we talk about my wheelchair pushers, they tend to push and everything is forward, and they get very tight forward, and they don't have the flexibility with abduction and external rotation. You don't want to pull on an arm that's unstable, both in a stroke patient and a spinal cord patient. And pain prevention is the goal. Again, the direct pressure and then the positioning. But I wanted to show you pictures of this. This is somebody who we have prone, which is a nice position because our main risk for pressure sores is sacral and ischium when they're lying in bed, and heel. If you can get them in a prone position, this decreases a lot of pressure in their normal pressure areas. But you want to, the shoulders in abduction here. The chest is supported, the knee is supported. They don't have any hard pressure anywhere. And then when they're lying on their side, again, the whole arm is supported by a pillow. This arm is externally rotated, which is helpful. When lying down prone, you can see they externally rotate this shoulder to give us some good stretch. And then, if we're lying flat on their back, this is the position we kind of like to position them in now and then. Now, the problem is none of our patients like this position. They don't tend to, but if you can get them into it and stretched, for 15, 20 minutes a day, that can be just a good exercise for them to do. And when we turn them, we don't really need to turn them. We need to get them off the sacrum and the ischium. 30 degrees is often enough. Going all the way over on your shoulder can be very detrimental. And so that's kind of how we'd like to position patients in bed, if at all possible. Again, joint position, we talked about minimize maximum extension at the wrist with transfers, avoid overhead positions, again, this kind of repetitive thing I'm talking about, and avoid the impingement positioning when they're reaching. And again, simply opening the palm up avoids impingement when they're trying to reach above head. And if they get into those habits, that can be helpful. Now, if they're having trouble with transfers and they're having a lot of shoulder pain, there's different transfer devices that can be used to both help family and the patients. Hoyer lifts with the manual hydraulic. There's the power lifts, which have a power assist and often have a longer track arm to get patients up and about. And then you can have an overhead system, which can be either with a bar system like you see here, or it can be put in the ceiling, and then you can position the patient anywhere, which can be very helpful, especially when getting in and out of a bathtub or some type of device where it's hard to get them up and over with the Hoyer lift. Now, a lot of what happens with the Hoyer lift, my experience has been that it takes time to put somebody in a Hoyer lift, put them in a U-sling, get them over there, and most of the time patients tend to just do sliding board transfers or pivot transfers just because it's easier and quicker for them. But once you get good at this, and if you're really having back problems or shoulder problems, this can be a lifesaver. Picture some sliding boards that can be used. You have a long sliding board, which we tend to use for car transfers because you don't get your wheelchair so close to the car doors. Shorter transfer boards are easier to transport and easier to use when you're getting in and out of bed. And then this is a board with cutouts. This one far to your left, where somebody who has a weak grasp can put their hand in there to position the board, so a high quad could use this board by himself if he had to. So transfer devices are used to reduce forces on the joints when they're transferring, reduce the force needed for lateral movement when transferring, especially the shear with the drag and your tetraplegics. Allow the transfer to be broken up into smaller segments so that you don't have to go all the way from the wheelchair to the mat in one motion. You can take small little jolts or jumps when you're doing it. And the use of mechanical or power lifts should be considered if the caregiver's getting older, or you're putting them at risk, or to avoid a lot of stress on a limb. So if somebody's really having trouble with transfers at home, I tell my patients to think about your transfers. I tell them you only have so many transfers in your life. How are you going to use them? You want to plan your day out to minimize transfers. You want to work with people that are there. If you can get help, get help when you can. For transfers. Now, the other thing is relative rest is something you want to do. Somebody has hurt their shoulder, hurt their wrist, hurt their arm. We don't want them to stop doing everything, if at all possible. So we try to give them relative rest. And so if you can put somebody in resting night splints if they're having a carpal tunnel, we use that a lot. Or, their elbow, if they're having problems with their elbow, or their shoulder, if you can kind of position and rest that in a neutral posture, that's something you can do. We often use pillow splints, just wrap a pillow around somebody's joint and ace wrap it just to give nice pressure support for that area. And that's an easy, cheap modification. Look at home mods, additional assistance if they need it. Do you need somebody to help you with your transfers when you're getting in and out of a car? Can you have somebody meet you at different places to help you when you're going into your office? I can remember my sister talking about getting in and out of her office was a real chore because there was like 5 doors and she had to go through it. And if somebody would just open a door, it would have made things easier for her. So sometimes you can call if you got an office mate, hey, I'm coming in, do you mind opening the door for me? Things like that. Plan ahead. And if pain can't be relieved with complete rest, and this is kind of old school. We used to admit people for tune-ups, into the hospital, but those hospital admission days are over. VA still has a little bit of that where they can admit somebody for respite. I can remember having a conversation with somebody that's having shoulder pain. We're talking about surgery on it. She had no family at home. She'd have to be admitted to a nursing home post-surgical. And sometimes, you talk about those things. Maybe we need to go into a nursing home for a little bit of time. When we think about pharmacotherapy with pain, we like to use non-opioids as much as possible, again, because it affects the neurogenic bowel in a spinal cord patient. Acetaminophen or NSAIDs can be used. Watch out for the side effects on the liver and the gut for moderate pain. Opioid analgesics can be used. I think you want to use them in a smart manner. Usually you use it when the others don't work. You want to make sure they don't have a substance abuse history because you can make them prone to problems down the road. Monitor for side effects, mainly bowels in our spinal cord patients. And then you want to, get them off the dose as soon as you can with most of these patients. And most spinal cord patients don't need narcotics. A lot of them are on narcotics. I see them. We have this discussion a lot. You habituate to narcotics, and it really affects their bowel program. And consider adjuvant medications, antidepressants, anticonvulsants, muscle relaxers. Steroid injections can be used for the shoulder, especially if you're trying to get somebody up and going in therapy and they're having a lot of pain with the initial activities, and it's something to consider. So again, the corticosteroids facilitate physical activity for cases where inflammation is a problem, and it's used to get the exercise program going. Prolotherapy can be used for somebody with chronic rotator cuff tear. And prolotherapy, if you're not familiar with it, is proliferant therapy is the other name for it, but they use something to cause inflammation, unlike your corticosteroids. Typically, it's dextrose at a 12% or 25% solution, injected into the area of injury or pain, increases blood supply to the area, increases healing. And that can be very helpful. And then finally, and this is becoming more popular in the sports world, but also arthritis, is platelet-rich plasma, where they spin down your own blood and you can inject it into the joint area to help with tendinopathies and arthritis and to avoid surgeries. When you're doing exercises, flexibility exercises, you want to do about 2 to 3 times a week to really stretch it. Again, those external rotators, you want to mobilize the scapula as much as you can. You want to kind of fight the natural forces they have for the wheelchair pushers to kind of stretch them into the external rotation position. And general prolonged stretch, again, avoid the internal rotation overhead activities, which I've kind of harped helped on a lot. When you're doing weight activities, 8 to 10 exercises with 8 to 12 reps, kind of a similar thing that you do with your able bodies. Start with low resistance and work up, pain-free fatigue. You don't want to over-weaken the muscles, because then if they have to transfer, they go to the gym and work out and then can't transfer themselves into the car, you're really not helping them much. So you got to make sure they can still do their activities after they lift weights. You want to pay particular shoulder depressors, infraspinatus, subscap, latissimus dorsi, and the stabilizers, the rhomboids. If you can really stabilize the back, we talk about the Mercedes front and the Volkswagen back. You want to really get a Mercedes both ways so you can get good, strong shoulder stabilizers, shoulder depressors, and not just pecs. The world is not just about pecs. And then limb impingement, which, I keep harping on that. Relative rest is difficult. We already talked about that with the splinting and maintain optimal range. Look at alternative activities. Again, if somebody's, you can't keep doing the same thing and expect the pain to go away. So if transfers are causing their pain, we got to think how we're going to transfer different. Do we need an assisted device? Do you need a sliding board where you're not using a sliding board? Do you need to level your surface when you transfer? Do you need extra assistance when you transfer? So just think about what they're doing that's causing the pain. And then a gradual return to activity once you get them better, monitor the results. And then surgery is an option. It's one that is, I would say, the last option you want to go to is with spinal cord patients because of the effect that it's going to have long-term on their shoulder. But if somebody has chronic neuromusculoskeletal pain, fail to regain functional capacity with your treatment method, and they give it, in the guidelines, they look at about 3 months. If you're not getting where you need to go, you're limiting their function, and they're not getting there 3 months. I had one patient who had a known rotator cuff tear that I was managing. She's a manual wheelchair pusher, and we were doing prolotherapy in the area of her supraspinatus tear, and it was, we went about 6 months, to keep trying to do it. She finally decided to go ahead and have it repaired, but when we did that, we got her power wheelchair during the repair process. We got a Hoyer lift and a hospital bed so she could, because she was non-weight bearing for I think 8 weeks after the shoulder surgery. So you got to just, if you're going to do that, you got to plan ahead. Recovery times, we just talked about that. So if they have a carpal tunnel release, that's 3 weeks of not using one hand. If you're a manual wheelchair pusher, how are you going to manage that? If you have an open carpal tunnel, it's 8 weeks. Rotator cuff decompression repair, 6 months. And I just saw my patient after her repair. She's back pushing a manual wheelchair, actually doing quite well. So the repair went well, but 6 months of limited activity. Her husband had to do a lot more. Now nerve grafts, I'll talk about that. A lot shorter recovery period, and then tendon transfers, which we'll talk a little bit about to improve function, is about 8 weeks after that surgery. So you have to plan when they do that. So when we're looking at tendon transfer surgeries, there's two motions that really help patients if they lose it. So if you have somebody with a C6 function, they don't have C7, then their ability to reach up, they can cheat by turning the hand up and raising them, but once they get to that tipping point, then the hand comes down and they really can't grasp something above. So giving them a little bit of elbow extension can be very helpful, also for hand placement to grab things. And if they don't have wrist extension and they lose that tenodesis grasp, so somebody with a C5 who doesn't have wrist extension and cannot hold anything in their hand, they have to use a universal cuff, you can provide that by doing a tendon transfer. So with elbow extension, oftentimes you can use the biceps brachii and tunnel it through and attach it to the triceps muscle to give them elbow extension. The other thing you can do is use the posterior deltoid and tie it into their triceps to give them just enough. Now you're sacrificing a little bit of deltoid, you're sacrificing a little bit of bicep to gain the function that you want. And then finally, for wrist extension, the brachioradialis is a very nice muscle that's used for elbow flexion, but you can take that muscle and tie it into your wrist extensors, or you can tie it into finger flexors, and actually you can get a little bit of thumb pinch too. You could tie your bicep or your brachioradialis to restore function. So those surgeries are available to help patients with function, but you're talking 8 weeks recovery process. There's also other muscles that I mentioned at the bottom. You can use the extensor carpi radialis longus, pronator teres for pronation. You lose that, but you can gain some other activity by that transfer. Now, something that's becoming a little more prevalent and prominent is just really being looked at is nerve transfer surgery, where you can take a donor muscle, which is you don't really need as much, or you can take, from the deltoid, you can take one of the nerve inputs to the deltoid and tie that into another muscle group, or use a supinator or brachialis and to innervate another muscle that you want to do. And you can do multiple nerve transfers. You can do a deltoid and a supinator or brachialis to the wrist extensors, below the level of injury, to restore that function, to get elbow extension, wrist extension, or hand function. Posterior interosseous nerve is often used, or anterior interosseous nerve can be very helpful. And early results are very encouraging. If we do a distal nerve transfer, it grows a lot quicker and innervates quicker, reduce time for the axons to grow. If you do something proximal and distal, it takes longer to reinnervate. And so, you want to do that early, and you avoid chronic deinnervation. So this technique is still probably in its infancy. It does not require prolonged immobilization. Greater functional gain is what we're seeing. You can do several upper limb functions at the same time by doing different nerve transfers, and you can do it in a single stage. So this is kind of exciting for a lot of our patients, but it's fairly new, and the surgeons are just trying to learn how to do it. So there's different assisted devices that we can use if we can't get our nerve function. I mentioned if you don't have tenodesis grass, you can use what's called a universal cuff, which can wrap around your wrist, and you stick a fork in a little pocket so you can hold something. I already showed you the wrist-driven flexor hinge splint. This is another universal cuff just with a side view. And this is a dorsal wrist support. If somebody doesn't have good wrist stability, you can stabilize that wrist so that they can use the hand more functionally. And then these are little tenodesis devices. Again, this is universal cuff with that pocket that you can see end on. And then this stabilizes the thumb to augment their tenodesis grass. So those are the things that I wanted to kind of talk about. I think, the things that I want to drive home, if somebody's having shoulder pain after spinal cord injury, you want to look at what they're doing. What's causing the pain? And then what can we do to modify those activities to decrease their pain, and then get a treatment strategy on board that can get them where they need to go. And if it's not working, then you got to reconsider things.